It's with great pleasure that I introduce a very distinguished professorship, one of our many named lectureships here at UC Davis, our Mott Lectureship. Just to remind all of you, the Mott Lectureship, as it's indicated on the back of your program, is really a celebration of the relationship between the Kaiser system and the UC Davis system, and that this celebrates that relationship. And John Mott was a faculty member who ultimately went on to participate in developing the Kaiser system in the Sacramento region. And this has been a long-standing and important relationship for our community and for UC Davis. So with that, I would like to invite Dr. Cook to introduce our distinguished Mott lecturer for today.
So it's a great pleasure and honor to introduce my friend and colleague, Dr. Tom Varghese, Jr. I've known Tom for several years, now over a decade. Before I introduce Tom, I just want to note that Tom follows a long line of great scientists and physicians who have spoken the Mott Lecture. The first speaker is Dr. Jonas Salk, and our last speaker was Dr. Valerie Rouche. So Tom, either you win a Nobel Prize or you become president of ACS, American College of Surgeons. So that you get to pick which one you get to do after this lecture. Dr. Tom Varghese is the Executive Medical Director at the Huntsman Cancer Institute, head of the section of general thoracic surgery, and Program Director of cardiothoracic surgery at the University of Utah. He holds several national leadership positions, including the Society of Thoracic Surgeons, American College of Surgeons, and the SUS. He is co-chair of the Association for Women Surgeons, He for She Task Force, and really is an advocate for gender equity in surgery and cardiothoracic surgery. And he's an accomplished health services researcher, past president of the Thoracic Surgery Outcomes Research Network, and founding member of that organization, and has R01 funding from the National Center Institute on Role of Precision Exercise Prescription, which you'll talk about. The first time I ever met Tom was electronically. I was a senior resident about to graduate from general surgery, and I get an email. I was going to be a general thoracic track resident at the University of Michigan, and I got an email from Tom, who's the chief resident, rising chief resident, to describe my rotations for the year. And I opened up the email and saw my rotations, and I saw it was 75% cardiac surgery and 25% thoracic surgery. So I emailed him and said, well, I was the thoracic track resident. How come I'm not doing more thoracic surgery? And he replied, oh, you just have to get it out of your system. We'll get the cardiac surgery out of your system, and then you can do thoracic in your final year. So with no further delay, Dr. Tom Varghese.
Thank you, David. Hopefully this is, yep, it is. There were so many other stories that could have been told right there, so I was just wait, but I appreciate the kind comments. And it is a incredible pleasure to be here. I'm a huge fan of the UC Davis health system. I think it's amazing that you have this unique balance here of very accomplished academic faculty who never forget the mission of why we do the things we do. And the reason why we do this is that our job is to help everybody, not just the rich. Our job is really to help everybody. And I've been, in the short period of time I've had here, I see that in every single thing that you do. I think the kindest words about me were told by Dr. Farmer last night at dinner. She affectionately described me as a troublemaker, which I think that, also to close the loop, Jerry and I have known each other for a long period of time. My first faculty position was at the University of Washington, and literally my first office was right down the hall from Jerry's. Now, there was a size discrepancy between my office and Jerry's office, but that's a total different thing as well. For this talk this morning, a couple of disclosures. I did have initial funding for Strong for Surgery from what we like to call coalition funding. It was kind of a combination of traditional funding resources as well as from industry support. So, for example, the Life Science Discovery Fund was the huge pot of research money that was created as a result of the tobacco lawsuit settlements in Washington State. But the industry support was really for promotion of quality improvement programs and not for promotion of any specific commercial products as well. In 2016, Strong for Surgery officially became a quality program of the ACS, which I'll describe in the coming slides as well. And then, as David alluded to, I do have R1 funding from the National Cancer Institute for this exercise trial, and I'll be briefly describing that as well. And then I do also have funding for some of our quality efforts through the Huntsman Cancer Foundation Translational Award as well. These are the objectives. My talk's going to be in 3 different parts. I think that what it's going to be is really the first part is to review the trends in healthcare that's led to this concept of value-based care, to sort of describe both the ACS Strong for Surgery and the Utah Surgery Strive programs. And then the last part of my talk, really going to be talking about kind of some trends or things that we can think about coming down the pipeline. And that last part is really focused at the younger folks in the audience. I think that we always like to say that we stand on the shoulders of giants. That is that we learn from the progress of the people, the innovators, the trailblazers ahead of us. But obviously this field needs to continue to evolve, and we need all of you to push the boundaries going forward as well. Another way to say this is we're going to start with the why, and then we're going to end with describing how we went about it and what we've accomplished till date. So I'll start with some dismal facts. Every year there's this concept that there may be preventable deaths. That is that any error or something that could have been caught in time led to something. We kind of scratched the surface a little bit this morning in M&M, but the estimate right now is about 210,000 preventable deaths each and every single year in the United States. And theorized about half of them are associated with a surgical intervention. 1 in 4 colon resections, 1 in 6 cardiac operations, 1 in 10 spine operations, there's readmissions. And that's estimated costs. And of course, there's this evidence of infections associated with surgery. And so why are these problems happening? I mean, we live in the greatest country on the planet Earth. We have the brightest minds all assembled together in the care of our patients. And one of the disturbing things that we think about is when we think about how we generate evidence, clinical trials, cohort prospective studies, guidelines, it's this disturbing fact. It takes an average of 15 to 17 years before findings from randomized clinical trials becomes incorporated into systematic practice. You name it. An aspirin after a heart attack. If you're on a beta blocker before surgery, continue the beta blocker after surgery. All these things, it took about 15 to 17 years, enhanced recovery after surgery. And so this delay in implementing evidence that we know works is costing money and costing lives. And we need to do a better job of translating those findings from the time that we find that it works into making sure it becomes delivered to patients each and every single time. This picture I kind of like. So the top left-hand corner, top right-hand corner is a cover of Time magazine in 1979. And there was a theme issue, and the big thing was healthcare is expensive, rising costs, we have to do something about it. The top left-hand corner are 2 reports that were issued from the Institute of Medicine. To Err is Human, that came out in 1998. That was the first time that they talked about this concept of preventable deaths. Back then it was about 148,000 preventable deaths. Crossing the Quality Chasm was a report that said that the problem in healthcare, that it was issued in 2003, that the problem is that we all exist in silos. We have expertise in a silo, but we don't talk to each other. And we got to do something to do that, do a better job to cross that chasm. Down on the bottom right-hand corner is everybody's favorite punching bag, the Affordable Care Act. Get opinions from all different parts of the political spectrum. And then the bottom left-hand corner is a bunch of acronyms, which seems that every year that more and more acronyms keep coming out. So what's the common theme that binds all these pictures? It's this. There is a feeling that public reporting is a mechanism to control costs. Every single one of those reports said that. Now, whatever we believe, whether we believe that's true or not, this is coming down the pipeline. And so the question really becomes, are we going to wait for a bunch of non-physicians and non-clinicians to determine what should be publicly reported, or should we be in the trenches and get involved and make sure that the outcomes that are reported and measured each and every single time are accurate and risk adjusted. Here's another theme that's emerging. So this is a fascinating study that came from the 4th hospital in China. And they looked at 53 years of esophagectomies, 21,000 patients. I mean, the number's staggering. And when you look at their outcomes, it's interesting. You see from a high volume center, with experience, they do better. Kind of makes sense. Their mortality rates plummet over time. And that makes sense to all of us in the audience. But interestingly, what's happening is it's not just at high volume centers. So this is a report that came from the Michigan group where they were looking at Medicare data from across the United States. And what they found is in every single one of these categories, everybody's doing better. Whether you're at a high volume center or a low volume center, and this is a great thing. This is something that we should celebrate. No question about it. Dr. Gawande kind of wrote about this in this New Yorker article from 2004, and what he described was an experiment that the CMS tried to do. What they did is, death is easy to measure. If we measure the death rates at different hospitals, is that a mechanism where we can differentiate a good hospital from a bad hospital? And lo and behold, they tried this experiment from 1986 to 1992, and it didn't work. Because there's not enough discrimination in death to determine if you're a good center or a bad center. Dr. Berwick went further and said, you know, we got to change the way we measure things. We got to open the books. We got to be very transparent about the process, make sure that people understand why we're doing the things we're doing, that this fear of litigation and everything, understandable, but we got to overcome that barrier. We got to make sure that we got to start sharing the results publicly and start discussing why we do the things we do. So these are the perspectives I just went about. Healthcare is inefficient. We know that. Healthcare is expensive. We know that. And we need to go beyond, let's not kill the patient. Let's not kill the patient is what we do each and every single day. But if we truly want to measure value and outcomes, we got to go beyond that. That's the key thing. So this article from the Harvard Business Review has become one of my touchstones that I keep going back to. It's pretty radical in some perspectives because they're talking about completely reorganizing all our healthcare delivery models along service lines to eliminate departments and things like that. I mean, that's a little bit of a radical thing. But there's one thing in there that really talks about. The first step in solving any problem is we need to achieve the proper goal. And it's really the overarching goal must be improving value for patients. And what they talk about in this is a value for patient is measuring the outcomes that are meaningful to patients over cost. The reason why cost becomes important is not because all of us are trying to make money. It's just because that's a surrogate way or mechanism to make sure that we deliver outcomes in an efficient manner and make sure that we're not wasting resources delivering those outcomes. But we need to start measuring the outcomes that matter to patients. That's the way forward, or the path forward. And that's really what value is about. Not a buzzword that marketers throw out there. This is what value is about. So when you start thinking about this, outcomes meaningful to patients, you have to start thinking about the journey a patient makes to the operating room. So many of us, for elective surgery, we meet patients in the clinic. That's where we talk to people, we diagnose the problem, we start talking about surgical options, non-surgical options. We really talk about the risks and benefits of the surgical intervention, get the informed consent, and then they go away. And then the next time we see a patient is when they walk into the operating room. And we do a pretty good job after they walk into the hospital. All our quality improvement metrics, keeping a patient warm at the time of surgery, decreasing blood transfusions, timely administrative antibiotics, all these things are all targeting after the patient shows up at our facility. But the question comes, why are we waiting for the patient to show up in our facility? What happens if we shift the spotlight to engaging patients from the first time that they walk into the clinic? Are there things that we can do to optimize their health? Is there anything that we can do to make sure that those patients are in the best possible shape coming into the surgical intervention and start engaging them from the first time that they walk into the clinic? So it's a paradigm shift. Why are we just talking about let's not kill a patient? Why don't we start optimizing? And that's really where the concept for Strong for Surgery came from. So Strong for Surgery is a program or a platform where the entire goal is what can we do to optimize the patient health before their surgical intervention. Now, the initial phases of this have always been targeting elective surgery, but you can make the argument that even in an urgent situation, if you got a little bit of time, or even in a trauma patient that you're taking urgently to the operating room, do you have a brief moment that you can tune them up? Is there anything you can do to optimize them before you walk into the operating room? That's really where the concept of Strong for Surgery is. It was really built on two principles: raising awareness and changing practice. This is kind of the two principles we talked about. So this all relates to how do we change behavior. So one of the things that we found is behavior change in the 21st century. If you're expecting your teams to do something, rather than dictating to them, this must be done, try to engage your teams. Explain to them the rationale for why you're doing this. So the way we did this is we created this public awareness campaign in the Pacific Northwest where really we were trying to explain the evidence behind why we were doing this. And then we coupled this with what we like to call implementation bundles. So these include standardized order sets, education metrics, checklists. Now this is where you have to dispel the myth. A checklist is not a passive document that hangs on a wall. If you believe that, nothing's going to get done. That checklist is actually a process improvement intervention. What you do is if a step on a checklist is not delivered, you have to ask the question why. Why was that? Was that because of a lack of a resource? Was that because of ignorance on the team? Was that because there was something critically missing? And then you go back and review that. That's how a checklist works. It's a dynamic communication tool. It's a dynamic education tool. It's a dynamic standardization tool. If you do that, checklist works. And so that's kind of how we created the implementation bundles as well. Here are the design principles. There were 6 steps. That was really what we talked about is try to understand why a site is participating in this. Try to understand what the critical problem or issue is at that particular site. Design with data. You know, whatever emotions and everything you have, if you have data and you measure it and it's accurate and you feed that back to the teams, they can understand what interventions are working or not. Do the hard work to make it simple. Design your first iterate again. Design your first version. Look at it. Wait a few months. Is it working? Is it easy for the teams to implement it? Iterate and make it simpler again. Keep doing the hard work to make it simple. Standardize the principles, but allow flexibility for the details so that UC Davis may do things differently from Stanford, believe it or not. But that's good. That we want people to do things that reflect the local environment that's easy to implement at their sites. And then, of course, make things open. The other thing, sort of checklists, each and every single checklist was designed with, if yes, what's the specific intervention that's tied with this? And so that if yes, what that specific intervention is, that can it be measured? And then you do it on top of a feedback platform. So those are the design principles that we had with Strong for Surgery. So we started in May of 2012, and we started thinking about pilot sites. So the goal for Strong for Surgery is we wanted to create an intervention that can be used for any type of surgical intervention in any type of surgical environment. So we partnered with our colleagues, most of them are colorectal surgeons in Washington State, but they represented all these different diverse practice environments, included academic centers, high volume private practice settings. Skagit Valley is a small community practice about an hour and a half from the Canadian border, Legacy Health in Portland, and then of course Harvard. We went to all the different practice environments. And the goal again was we were pilot testing this. So we pilot tested this for a year, and then in 2013 we started rolling this out to the Pacific Northwest. We targeted these 4 areas. These are not the only 4 areas for optimizing health, but these are the 4 areas. There was so much overwhelming evidence, over 40 years worth of evidence. There really wasn't any debate about these 4 areas. And so they include blood sugar control, medication optimization, smoking cessation, and nutritional optimization. So why do we pick these 4 areas? So why blood sugar? Simple thing, hyperglycemia at any time during your perioperative time period is associated with infections. One of the things, though, is when you really deep dive into the literature, it's not just diabetics. there's non-diabetics who get the hyperglycemia as well. And you start wondering, why is that happening? And there's this concept of prediabetes. That is, these patients, they respond to stress and trauma by having an elevated blood sugar level. And when you really look at this, it really becomes a rising epidemic. These pre-diabetics, they're not quite diabetic, it's just only in stressful situations. 35% of adults greater than 20 years, 50% greater than 65 years. Here's a different way of looking at this results. In your Medicare patient population, 1 in 4 is diabetic, 2 in 4 is pre-diabetic. 75% of your Medicare patient population. We've all had these patients. Mrs. Jones, post-op day 4, after an elective colectomy, you get a phone call. Hey, the blood sugar is 320. By then, it's too late. And so what is the way to mitigate this? Well, the easy thing to do is when they're fasting, on the pre-op holding area, check a random fasting blood sugar level. An hour after induction, check another blood sugar level. If those are fine, great. If they're elevated at any point, easy thing to do, start an insulin drip while you're in the operating room. Sounds kind of simple, but that's the way it is. Get the blood sugar control under control. Why medications? There are 51,000 dietary supplements on the market right now. When you ask a patient what medications they take, they respond by showing you their prescriptions. These herbal medications, all 8 of them, increase bleeding at the time of surgery. So what you have to do is you have to not only ask patients this, sometimes you have to show them pictures. And the evidence base for this is if any of your patients are on these herbal medications, you need to stop them 2 weeks before the surgery. Aspirin can be safely continued. In fact, especially if they've had a stroke or a heart attack or something like that, if they're on an aspirin before surgery, continue that throughout surgery. That risk of a perioperative stroke and a heart attack is much higher than any bleeding risk. Continue the aspirin. And of course, if you're on a beta blocker before surgery, continue the beta blocker after surgery as well. Why smoking? This is an amazing study that Dr. Mary Hahn, who's the chair of surgery at Stanford, did when she was at UAB. And so what this is these, the green is never smoker, the blue is prior smoker. That means that those who are smoking and they quit at least 3 to 4 weeks ahead of the surgical intervention. And of course, the gray is those who continue to smoke at the time of surgery. And the amazing thing about this graph is if you have a smoker and you stop them smoking at least a few weeks ahead of their surgical intervention, you can drop their risk of a complication down to the level of a never smoker. That's what this graph does. And the other thing that the study says is it's almost a dose response curve that you see. The more pack years that the patient is smoking at the time of surgery, their risk of surgical site infection, pulmonary complication, and 30-day mortality continues to go up. And why nutrition? We know that malnutrition is prevalent. And there is this concept of immuno nutrition may improve recovery. So what do I mean by immuno nutrition? First, the malnutrition aspect. If you measure serum albumin levels, this is in the SCOPE Collaborative in Washington State, you can see that when the albumin level fell below 3, quantifiably the risks of reoperations and death started going up. And for immunonutrition, the concept is at the time of trauma or stress, you can have arginine depletion, which leads to T-cell dysfunction, which then leads to increased risk of infection. And the way to combat this is that this is specifically in GI operations where there's a resection and anastomosis. You give them a 5-day supply of immunonutrition supplements. They come in these little juice boxes 3 times a day, and you give them for 5 days beforehand. You can drop the infection rates. So is there evidence for that? Yes, there is. This is the evidence. This is a systematic review. Again, most of this was in GI operations. And then 23 of them were used only preoperative randomized clinical trials and dropped the infections complications by about 43%. Now, there has been some pushback now in the literature recently about, is it really the immunonutrition? What about isocaloric supplements, any type of nutrition? That's totally fine. The problem right now is we're not doing any of this. We're not screening for any type of nutrition in surgical patients. So my answer back is, if you got immunonutrition, that's great. If you got something, booze, Ensure, whatever the heck you got, give them something. If they're malnourished, give them something ahead of the surgical intervention as well. So those are the 4 areas. In each of the 4 areas, we got stakeholders together, and we asked them, drill it down. If yes, what's the specific intervention? Maximum 3 to 4 lines on a checklist. Really, really drill it down. And then once you get this, translate this over into easy-to-use checklists. And so you'll notice that there were logos, there were color schemes. This was kind of designed in mind, but we also allowed the flexibility if participating sites wanted to put their logos, they wanted to, whatever it is totally fine, but it's really done intentionally each and every single way. So that's how we created the checklist, why we targeted the 4 areas. What about the raising awareness? What was the roadmap we used? So the way we did this was we got monthly conference calls with different stakeholders from the different sites. Surgeon's time, 6:30 a.m. on Wednesday mornings. That's what we ended up doing. New email listservs, email blasts, quarterly newsletters. There were speaking events. And then on top of all of that, we laid social media on top of that as well. So the changing practice that we talked about. There are different phases whenever you're trying to implement a quality program. The first phase is what's called the exploration phase. As you're assembling the team, you have to identify at the site, why should you do this? What is the burning issue at that site? Do you have a big problem with surgical soft tissue infections? Do you have a big problem with readmissions? What is the burning issue at that particular site? And then what you do is you do the initiate action. You assemble your change team, and then really the focus is the team dynamics. How frequently should you meet? Should it be formal in-person meetings? Should there be email communication? Really focus on the team dynamics as well. And then as you're doing that, you get the leadership support, and then you do what's called workflow mapping. So this is the components of a change team. They represent 4 different areas. There's those who do the day-to-day work, technical resources. You need champions, surgeon champions plus anybody else, and of course leadership sponsorship as well. Here's an example from the University of Washington. This is the colorectal surgical team, where what they did is they imagined the patient at the center, and then they imagined every single type of service that comes in contact with the patient throughout that hospital stay, before and afterwards. And then they got representatives from those teams in a room together and started talking to each other about how to create flame, how do we improve workflow as well. Another example of workflow mapping is what they did with my clinic at Harborview. So I led the thoracic program at Harborview, which is a county hospital, level 1 trauma center that serves about 5 states in the Pacific Northwest, where Jerry had led that effort for many decades. And when we started thinking about it, one of the things we found was the patient would park their car, come all the way to our clinic, halfway across the building, check in, got sent away to go get an x-ray, and then come all the way back. And when we did the workflow mapping, they were wasting about 30 to 40 minutes just in that process itself. The workflow mapping is we just redesigned things. We educated patients about stop an x-ray first and then come to clinic. Sounds simple, saved a ton of time. And if you save time, that's when it works. So if I go to a busy surgeon's clinic and I say, you're seeing about 30 patients, I have this great intervention, but it's going to add 5 to 10 minutes per patient. That thing is dead in the water. I have to find time there first. So that's why the workflow mapping becomes critically important, and why the change team becomes important about trying to make sure we design this in a way that it seamlessly incorporates into the surgeon's practice as well. So maximize the patient value, eliminate waste, and map out the process. Identify value and non-value steps, and then empower the staff. Empower your MAs, empower your clinic nurses, empower your residents to take a look and say, wow, that's working, great. That's not really working, let's tweak it, let's change it. In my clinic right now at the University of Utah, my MAs do the first process of doing the Strong for Surgery checklist, and then I go through my spiel and do the education, and then my clinic nurses reinforce that. That works in my clinic, but that may or may not work in your clinic. You got to identify what works in your clinic to make sure that this flows seamlessly as well. So that's the exploration phase, the initiate action, and the third phase is what we call learn together. The only way that we know, remember, design with data, but act with data as well. We have to make sure, what are we doing? Is it working each and every single time? And then feedback that to the teams to make sure that they understand all the different steps that's working and how to go forward as well. So, you can say, this sounds all warm and fuzzy, Tom. Did it work? Or was this just a colossal waste of time? So, the reach. As we talked about, we laid social media on top of this. We created a simple website, www.strongforsurgery.org. It was the most basic website in the world. We got, in 2 years, 173,000 hits to the website. Unique page views are those who not only go to the home page, but they're actually exploring different aspects of the website as well. This was an intervention targeted at the Pacific Northwest. What we found is we got 268 requests outside the Pacific Northwest, as well as requests from 15 different countries about asking if they could participate from Strong for Surgery. And why did that happen? All the stars are where I gave outreach talks. All the Twitter birds are where we got specific requests through social media and emails and things like that about sites wanting to participate in Strong for Surgery. And then, of course, that went globally. I wish I visited all these countries, but this is kind of the power of social media. That is, you're able to connect with a tribe of people around the world about different change opportunities as well. We got a lot of attention from traditional media reports. These are 2 articles in the Wall Street Journal. That's Doug, who's one of my early lung cancer patients, who showed up, uncontrolled blood pressure, poor blood sugar control, and really talked about the process of how we went about optimizing his health. And now he's not only cancer-free, he's living cancer-free. He's in the best shape of his life years later. A second report came out from the Wall Street Journal talking about the increasing use of apps, and that how the patients are really interested in engaging in their health, and that they're using these apps to go forward as well. This is from Consumer Reports. This is an interview with IHI, a patient safety blog, the Institute of Healthcare Improvement. Got a lot of attention that way as well. What about effectiveness? Did it work? So, the SCOPE Collaborative is similar to a lot of collaboratives like the NISCO Collaborative. It involves about 55 hospitals in Washington State. And so 3 years before SCOPE was launched, the composite adverse event rate is a statistical way of compiling all sorts of reoperations and mortality into a single metric. The composite adverse event rate for elective colorectal surgery was around 20%. 3 years after launch, they dropped it to about 10%. But the group said, is 10% enough? Can we do better? This still means 1 in 10 patients are having an adverse event. Or can we do better? So, by quarter 4 in 2014, remember, pilot phase in 2012, started rolling out in 2013. By quarter 4, 85% of patients, elective colorectal surgical patients in Washington State were Strong for Surgery checklisted. And when we looked at composite adverse event rates, that 10%, we dropped it to 7%. We then did a propensity-based match scoring where we did like patients to like, and the differences are even more staggering. 11.5% down to about 7%. And of course, when you do that, you decrease length of stay. And this was just using the nutrition checklist is what we were looking at. So those Immuno Nutrition supplements that we were talking about for those elective colorectal surgical patients, as well as the Strong for Surgery checklisting process. So an interesting thing happened. This is spine surgery in Washington State. We were rolling out, and in late 2013, Cigna announced that if you have a smoker and you're going to do a spine surgical intervention and you don't offer them any type of smoking cessation intervention, we're not going to reimburse your care. And as soon as they said that, all these orthopedic surgeons, spine surgeons, started coming out of the woodworks and say, Tom, we want to partner with you to do that. So all these dots represent different hospital groups and everything coming in. This is a better way of doing it. On the right-hand side, every dot is the smoking cessation rate. So smoking rates. That is, number of patients who are still continuing to smoke at the time of the surgical intervention. And the wide scatter really shows that the rates are all over the place and different hospitals have different outcomes. The left-hand side of the slide really shows that not only are each individual hospital doing better, the entire state is starting to do better. That because we did it on top of a public awareness campaign, the entire cohort is doing better in terms of smoking cessation rates. That is, they are offering smoking cessation programs and getting people to stop smoking before the surgical operations as well. This also, interesting, works at different sites. So this is Chris's Health in Texarkana, Texas. So when they started rolling out Strong for Surgery, they did it in a 1-2 punch. They did Strong for Surgery along with Enhanced Recovery. And right in the middle of the rollout, Hurricane Harvey hit. And then you're like, and when they called me, I'm like, geez, just be safe. Don't worry about Strong. But they persisted. They kept going through it as well. So from July 2017 to January 2018, they enrolled 290 patients. They were able to get their diabetic control from the mid-80s to almost 97%. The smoking rates, they dropped by about 10%. And then, because they did it coupled with enhanced recovery, they started shaving 1.5 days in their length of stay as well. So even a tiny hospital with limited resources in the middle of Texas, or towards the bottom of Texas, was able to do this as well. What we're seeing now is a 1-2 punch. A lot of programs are doing it along with their enhanced recovery programs as well. There were 8 sites initially in Washington State, and this is kind of the most common thing that we're seeing as well, that they're using Strong for Surgery coupled with their enhanced recovery protocols, and I'll come to this later on as well. What about adoption? We had, all these were formal endorsements. Obviously, they're Washington State heavy, but our 2 first national endorsements were from the American Lung Association and the American College of Surgeons. We talked about these are our pilot sites that we started with in 2012. At the end of 2015, we were at 50 sites involving 205 surgeons across the region. The American College of Surgeons took over in 2016. And now at the end of 2018, we're active at 230 sites and growing as we speak. And the reason why is the American College of Surgeons designated as a quality program. A quality program of the American College of Surgeons, as everybody knows in this room, has 4 pillars. Establish the standards, build the infrastructure, generate the robust data, and do a verification process. Everything I just described is essentially what we did for Strong for Surgery as well. These are all the different quality programs. As you can see, a lot of pictures and everything that you've seen very familiar. Last year, the American College of Surgeons came out with what's called the Red Book. This is the quality improvement Bible that we use. And what we did is we designated 5 phases of surgical care, perioperative care. This is where Strong for Surgery sits. This is where the enhanced recovery program sits. So you can see it's a 1-2 punch that seamlessly works in terms of optimizing patients and then continuing forward as well. When we get a new site that enrolls in Strong for Surgery, we have these learning management modules that they go through. This is the website. This is how things are screenshots of what it looks like. As the different programs go through all these different things, they find out why we created Strong for Surgery and different opportunities to go forward as well. In the closing moments I had, I'm going to talk about the future, what things that you can do as well. This is a remarkable study that just got published this month in Annals of Surgery. This is a group from Hopkins. What they said is when they found these modifiable risk factors for elective surgery, and then they sent them away to engage with non-surgeons to optimize them, the average cost was about $685 per patient, increased cost, but each time you save a complication, you're saving about $15,000 every complication. So that's a great return on investment as well. When I was recruited from the Washington State to the University of Utah, this is the Intermountain West region. That's Huntsman Cancer Hospital. And so what you start thinking about is this is a 1,200-mile catchment area. And what the University of Utah was known for was they had designed this thing called the VDO, the Value Driven Outcomes platform. This is something that's unique in our electronic data warehouse where we're not only able to measure costs, but we're able to drill it down to the level of if I use an extra gauze for this patient versus that patient, I can measure the difference, and I get that data fed back to me. So that was a platform that our previous dean had been championed as well. So we came up with this concept, the Surgery Strive concept. ST is strength training, also known as Strong for Surgery. Enhanced recovery. I is informatics, so we're designing apps and web-based platforms. V is the value-driven outcomes, and E is exceptional patient experience, patient satisfaction scores. The reason why that became important is the University of Utah was the first health system where we publicly reported our Press-Ganey patient satisfaction score. So that's my landing page on my academic website, and this is all the patient comments that we did it. Initially, when we started working on this, there was a lot of pushback. Now that everybody is doing it, we actually have a significant proportion of our providers, including myself, who this past year were in the top 10% of patient satisfaction scores across the nation. And oh, by the way, we're able to hang videos and everything on top of this. So when I first got recorded, I'm a diehard Chicago Cubs fan, so I recorded saying, I don't know if in my lifetime I'll ever see the Chicago Cubs win the World Series. That was recorded as part of that. I knew that patients were starting to look things up when they walk into clinic, and before I say anything, they say, How about them Cubs? So that means that all our patients are actively looking and deep diving in to try to figure out what drives us and how we go about things as well. We created this. This is a clinical trial. It's called the PEP trial, the Precision Exercise Prescription. And so the way we designed this is once we did the workflow mapping and everything in our clinic, I actually have a physical therapist that sits in clinic with me. And what they do is for lung cancer interventions, surgical interventions, they take the patient down the hall and we do a 6-minute walk. And it's amazing just by doing that simple thing. Because you think your eyeball test is pretty good and you're like, yeah, that person's pretty funny. You get them to walk and you measure it. There's a lot of things that pops up as well. So the 3 PIs for this, myself, Neely Ulrich is the head of cancer population science. In her prior life, she used to control all the clinical trials in the country of Germany. Paul Lesteo is the head of physical therapy. So the 3 of us kind of partnered together to do this. And this is the intervention. We created an intervention that can work from even the most debilitated patients to even those who are scaling mountains. That we will do that. And the way we did that is we could do this, what's called the AMPAC mobility scoring system. So stage 1 and 2, and then stage 3, 4, 5. 5 is your athlete. The vast majority of us live in stage 4, but you can see that with this intervention, we measure it, and then we try to come up with aerobic and resistance exercises for every single patient, each and every single time. We have an intervention for everybody. We got the 4 checklists we talked about. Those are the 4 different areas. This past year, we've created 4 more checklists. Safe, effective pain control, prehabilitation, patient directives, and delirium screening. I'm just going to rapidly show you some screenshots going forward. That's optimal pain control with the opioid pain epidemic. We realized that there were a lot of patient education handouts that the college had already generated. We just tried to organize them all under one umbrella. These are prehabilitation, kind of similar to the exercise trial that we're doing right now. Patient directives. This is the first time that everybody's ever talked about, should you be doing the operation? Is it appropriate or not? And one of the tools that we're doing is what's called this best case, worst case tool that Dr. Gretchen Schwartzy designed at the University of Wisconsin. Essentially what you do is you describe the best outcome for that patient, you describe the worst outcome from the patient, and then in that, the 2 extremes, and try to figure out where they sit. There's a lot of YouTube videos that you can find as well. Interesting, what you'll find is, especially in advanced cancer, death is not always the worst outcome. The worst outcome sometimes for patients are if they were independent and functioning at home, and if you say, I can do something that'll save your life, but you're going to be stuck in a nursing home for the next 8 months of your life, sometimes that becomes the worst outcome. And you have to talk to those patients about that each and every single time. Like I said, you can find these YouTube videos as well to find out about this. And then about delirium screening as well. In each of those 4 areas, same process, content, stakeholders together. If yes, what's a specific intervention? And then you deliver the checklist as well. And those are our 8 checklists. Now you think about it, you're like, wow, that's 8 checklists. I can easily think about 10 other areas we can optimize health. Think about how clunky that looks. And so what we realize is we have to start generating web-based platforms. And the goal of this is eventually to start creating a website and an app where you can imagine you screen patients, all sorts of different checklists, you figure that out, you get one specific patient-specific checklist that gets hardwired into an app, and then that reports data back to the participating site. This is what we're working on right now in terms of the next steps, in terms of making sure we can deliver care each and every single time. So it was interesting, I read your vision statement at UC Davis, and I saw the slide this morning and said that one of your vision statement is, here is creating a healthier world through bold innovation. Now you can make an argument about bold innovation. Isn't all innovation supposed to be bold? But that's a total different discussion point and everything like that. But for the young people in the room, what do we mean by innovation? There's 3 ways of doing innovation. What we usually think about is if you create a product that doesn't exist. This is what Apple does, right? iPhones didn't exist. Now everybody has an iPhone. And that's one way of innovating. There's 2 other ways of innovating. The other way of innovating is that if you introduce a service in a new way that hasn't been done before. That's Google. Google was the 21st search engine that was introduced into the market. Not the first, the 21st. They improved on the previous 20 versions and now have done it better. And then the other way of doing it is diffusing that product in every single space that you can imagine in terms of thinking about it in terms of engaging. This is Amazon. You know, Amazon started selling books. Now they sell everything from socks, underwear, on upwards as well. So, Apple, Google, and Amazon. How does that translate into surgeons? The way it translates into surgeons is this. We need surgeons to start getting involved in public health initiatives, clinical trials, big data. I'm not talking about big databases. I'm talking about every single aspect of your life. If you look on our smartphones, and if I ask you what are the 5 apps that you use most commonly, I can kind of describe what you do in your day-to-day life just by asking that simple question. Collaboratives, that we are better together, not by ourselves. This is kind of the future. And so what are the examples? This is a great book by Dr. Brian Bartavian, who's a pediatric GI specialist down at Baylor. And this is free, available on Apple Books. And he talks about these are the different ways that you can engage in the public sphere. That is that you can create, you can curate, you can collect different best practices everywhere, engage in conversations, and then consumption, that you are an active consumer of the content that is out there as well. I kind of coined this term of I to the fourth. What do I mean by that in social media? What you do is you create your brand through a series of interactions, you generate influence, and ultimately you create lasting impact. I to the fourth. And I think that this is kind of a useful paradigm thing to think about is how you engage with the public as well. What do you stand for? What are you representing to your patients, to your community? How can you tell your story to make sure that we know what you're doing each and every single time? This is my Twitter website, the Twitter page. You can see that I have 16,900 followers. It's not the number, though. It's the impact that you create through the conversations as well. Last year, I wrote a blog post called Building Your Digital Presence as a Surgeon. This blog post was the most accessed, downloaded part of the STS website this entire past year, which is amazing because if you think about the STS, there's database stuff and there's other stuff on there, but more people were driven to this, which shows that we're starting to resonate. I wrote a part 2 for this about scholarly work in an ever-changing, talking about altimetrics, H-index, different ways to measure your impact in this thing. And you know, obviously, shamelessly plugging, please go read it and find out what other things that we can do. And I'm interested to hear your feedback about how we can improve this going forward as well. In terms of collaboratives, we've branched out. We're active, Strong for Surgery is working with the Coalition for Geriatric Surgeons. This is Dr. Zara Cooper and their group at the Brigham has started talking about palliative care. And I was a keynote speaker recently at the ASER, that's the American Society of Enhanced Recovery, and we're doing an active collaboration as well. This is a collaborative that Dr. Cook talked about. What we did is that we got a bunch of leading thoracic health services researchers together from across the nation. Well, actually, it's 24 institutions in the United States and 2 in Canada. There are 29 members. And the reason why we did this is now imagine if we find from a small study in a randomized clinical trial that something works. We now have a framework to testing that in real time out there across, rapidly accumulate numbers, and then it's a mechanism to disseminate those results back to the community. We're speeding things up, so we're not waiting 15 to 17 years anymore to implement things that we know that works. So this is the future. The future is really thinking about every single contact that the patient has with the health system. They go for a screening mammogram, start optimizing their health. They go get a flu vaccine, start optimizing their health. That we serve a community and every single contact that they have with the health system is an opportunity to engage those patients. And so we're broadening that spotlight and not just relying anymore on when the patient shows up in the clinic. That really is the future going forward. And so my final points I say is define value in your system. Every single system, there's similar themes, but there's differences. Define that value. Assemble the change teams and think about the phases of implementation. And I think not just collaboration, hyper-collaboration. What do I mean by that? Collaboration within your system, collaboration outside of your system. That's what I mean by hyper-collaboration. That really is the future going forward in terms of how we make a difference to our community, to the state, to the nation as a whole. So My final thoughts are this wouldn't have worked without the amazing work of tons of people. You can see a lot of young faces, a lot of general surgery residents. General surgery residents did research projects, really engaged in everything in this space. But the most important part were with the outreach talks, we started talking and everything. But obviously, at the end, it was about the patients and their patient advocates. We wouldn't have been able to accomplish anything without their amazing feedback and the amazing work that they did. If you guys are available, in July is our patient safety, quality and safety conference in Washington, D.C. There's a separate track for Strong for Surgery there as well. And for those who are interested, Susan is our point of contact person at the American College of Surgeons in terms of engaging going forward. Thank you.
So, Tom, I just want to thank you for this incredible lectureship. I want you to know that this, despite the fact that it might look like a weapon, it does get through the
TSA is on this. That's totally fine. I appreciate it.
Your talk really reminded me of a comment that I made to our graduating chief residents fairly recently, that there is no satisfactory substitute for excellence from Beckman originally. That there's all kinds of reasons and excuses to not do something, but in fact, with respect to getting our patients ready, it is without a doubt the right thing to do.
Absolutely. I mean, and the only thing I would echo on that is, I think that every single one of us, if you think about what we do in our day-to-day lives, let's say we go on vacation. Do we just jump on a plane and then show up there and then say, okay, now I'll decide what I'm going to do? No. We read up about where we're going. We go on TripAdvisor to say, oh, is this yes? We have a few outliers. Okay, never mind. Never mind, just ignore this part. No, but the thing is, we ask our friends. We look things up. We go to TripAdvisor. So in every single sphere of our lives, we're hardwired to make sure we prepare ourselves before we show up. Patients are the same way. Before they, undergo, they're asking those questions. They're asking their neighbors, hey, did you have you had a hip replacement as well? How was that? They're asking, is this doctor any good or not? I mean, there's all these conversations going on. So patients, I think, are interested to engage in their health. And the best way to do it is we can help them along the way as well.
I just want to, make a comment when Dr. Varghese, who I was pleased to just be able to honor for, getting
absolutely the colorectal excellence. That's amazing.
The second on the west of the Mississippi, this program, and why don't you describe the trouble you had, sort of getting the nutrition drinks for our patients who we discovered couldn't afford them.
Yeah.
I was going to ask you about that.
Yeah.
I actually have been using Immuno Nutrition since 2007. Now, when I was in Pittsburgh patients will do anything their doctor tells them to do, so it wasn't an issue.
Yeah.
They would pay for them. North Carolina started to get a drop off. Came to California even more so, because the patients just would not pay for it. It was hard to get buy-in from leadership, so then we did half and half, such that the Division of Colorectal Surgery paid for half of the trains, a hospital would pay for half of the trains. And that was the only way to then
get things going. Yeah.
Which was cost that the patients would not literally buy into the
Yeah, and then on top of that, we're among friends. I really got pissed off recently because all the nutrition companies, when they started seeing the sales go up with this, they started raising their prices on top of that as well. So the cheapest Immuno Nutrition 5-day supply is about $60. I think the ways around that is if the health system negotiates the contract, you can plummet the cost to about $25 to $30, but still $25 to $30 per patient. We're having some ongoing conversations right now with insurance companies about really trying to show them the return on investment. It really does make sense. That's a work in progress, but I completely agree. I mean, I think the ideal world would be if you have the nutrition supplements like literally in your clinic or at the pharmacy inside your building so that the patients, after they talk about it, you just hand it to them and then they walk out the door. That's the ideal world. But I hear you in terms of the costs and everything like that. The question for us right now is we actually have some discussions going on as should Strong for Surgery go global? And if it does go global, are there interesting homemade recipes and everything that we can tap into, like countries in Africa or something like that can do for their patients? Those are the kind of things that we're getting there. We're not quite there yet, but I hear where you're coming from. Absolutely. That is a barrier that we need to overcome together as well. No, so Utah, well, it's extremely discounted. They pay about $15 per patient. And what we do is we house it in our pharmacy that's right in the building itself. And so we, even though they don't need a prescription, we kind of give them a prescription so we can track. And so what you do is we give them a prescription, they walk down the hall and they pick it up on the way out, but they still have to pay $15 per person. But that was because we bought it in bulk, and so we were able to steeply discount that. The system, so the Huntsman Cancer Institute and the University of Utah Health System bought it. So the system bought it so that we could get it rapidly discounted as well. We still get a little bit of money back as well.
I can't resist making the comment of all the people who complained to me that she was just being annoying by, demanding that.
She's my people. I mean, there's like troublemakers, right? She's totally my people as well. I see a number of hands.
The issue of implementation is really.
Go ahead.
Christine.
So one of the things in trying to optimize patients, you need to have partnership with the primary care and family practice people. Have you reached out to them to go over what Strong for Surgery is and how they can?
Yeah, actually we have. Now primary care, it's tough. They've got like 40 patients that they're trying to see at like 5-10 minute intervals and everything. So what we've done is some primary care practices are like, hey, thank you for letting, we communicate with them that we're doing this just so that they're aware. There are some small groups that have empowered, and so they've gotten to the point now that when they're referring a patient to me, they start already doing the checklist and everything on a kind of a low-key format. But I do think that it's an opportunity for you to collaborate with your primary care practices to try to figure out what works for them. Do they want to do it themselves, or do they want to just know about it and then kind of feedback as well in terms of activities going forward. So, sorry, go ahead.
Dr. Rossi.
I think that was a great talk. Thanks so much. I was curious if you've been able to change your format to more of the integrated practice unit that part of the HBR talks about.
Yeah, it's
into your clinic.
Yeah, that's the ideal goal. The problem we get back is the departmental silos. So like, for example, the cardiovascular service line, they measure the cardiovascular service line, but is cardiology and cardiac surgery and vascular surgery, do they really measure outcomes altogether? Kind of. So that's the problem with it. I mean, if you truly want to go to the integrated practice unit thing that they talked about, that Porter and Lee talked about, you really have to dismantle your complete infrastructure and start from scratch. We're not quite there yet, but work in progress. We'll kind of see how things are from there. Sorry, Jerry, go ahead.
Thomas, great talk. Really nice summary and a tremendous amount of personal work, I think, to try to pull this across. I think it's a testament to your leadership that people bought in those large groups and did this, not in just one area or in one state, but now in multiple states and now in the country. So really a huge congratulations. I wonder if you could talk a little bit about the social media issue and about the value of, there's a number of commercially available small software platforms that try to engage patients through their iPhone or smartphone during, before, and after surgery. And we're the future of those sort of platforms.
Yeah, no, it's a great, there's Seamless MD, there's a lot of things that are out there and everything. I mean, we've had, is that what you guys have here? There's ME Solutions. There's a number out there.
We have that too.
You have that too. So I think that we've been trying to talk to them about, they resist somebody like me peeking under the hood because they don't want me to know all their secrets type of thing. So it's been kind of a weird standoffish type of thing. I'm sitting there going, listen, you guys are already there. This can help. I think what's going to happen is, what may end up happening is if you have both ME Solutions and Seamless MD here at UC Davis, probably this could be an opportunity of just saying, hey, we're interested in participating in this, and then we can come back and just kind of, like for us, we have no problem. Here are all the checklists, here's the implementation bundles, go for it, run with it and see what works. Because the only thing we ask is, somebody always asks me, do we charge money to participate in Strong for Surgery? And the answer is no. It's completely free. The only thing we ask is, whatever you do with Strong for Surgery, let us know if it worked or not. Because then what we can then do is use those lessons and then kind of spread it to another site. So I think that's going to be the solution for these software. And I think this goes back to the local environment. If your local environment already has something, we don't need to reinvent the wheel. We just work with whatever you have going on there. And it's Strong for Surgery is designed to be modular so that theoretically it can fit into whatever's working as well. Lisa.
Great talk, Tom, and it's so great to see that something we all know is important and to show that you actually implemented it and it moved the needle for very important outcomes. Now, another seemingly simple concept is, like you talked about, measuring what matters to the patients.
Yeah.
So readmissions, mortality, morbidity, obviously important. But
Don't.
what about us thoracic surgeons who have, opioid naive patients? 14% of them are still using opiates.
Yeah, so I think that it's an interesting, yeah, how do you measure that? So it's an interesting thing. So with my new role as the Chief Value Officer and the Executive Medical Director of Huntsman, we have three principles: patient first, united effort, excellence in all we do. The united effort means that what we do is we discuss things collaboratively in tumor boards, enroll patients in clinical trials. Excellence in all we do is the patient metrics, like the length of stay, things like that, but we're also looking at care of the teams, like burnout metrics and things like that. But going back to the patient first. So what we did is the patient exceptional patient experience, the Press Ganey patient satisfaction report scores. In conjunction with that, we're starting to measure patient-reported outcomes. So we've hardwired PROMIS scores in our clinics and everything to really figure it out. We already have early data that, like for advanced cancer, that emotional status and fatigue is almost an independent risk factor, independent of stage, in terms of outcomes of the patient, which is it's a fascinating thing. So it's you're saying that it doesn't matter what stage of cancer you have, if you're not emotionally prepared to deal with that, or you're distressed, or you're fatigued, we got to do something. So what we did is we set up things where we have what are called distress alerts. Like if they score a high, when they're entering their data, if they score high, immediately right there and then social workers and financial counselors come and start talking to the patient right then and there. And so I think those are the type of things. So for the opioid naive group, I think that patient education, really drilling down into the emotional status. Are there things going on in their life outside that's affecting things? I mean, obviously with anybody with cancer, the first thing you think about is, am I going to die? And that's a huge impact. Is that driving some of the opioid addiction? I mean, I think those are the things we have to untangle going forward as well. Great question, but I think that's where there's a lot of opportunity to innovate and do robust research going forward as well.
Well, Tom, I just want to thank you again for a fabulous morning and a fabulous visit with us.
Thank you. Thank you.